Good morning, everyone. Good morning and welcome to this session on menopause. To all the people who are recently joined, there is a link on the chat box now, which has the link to the pre-lecture assessment. It's just a set of few questions which we would like to ask you about the topic. It has no bearing on your participation or certification, but if we need that for us to be able to send you that category 1 certificate of attendance. So please go ahead and fill that while we are just waiting for maybe 1 more minute and then we will start the session. Yes, if there's any questions, if you can please put it on the chat box, then our team will try and sort it out for you and get back to you. If you have any questions about the topic, again, please put them in the chat box and we will address them during the discussion. Seher, if I can just get your feedback, is my screen being seen clearly?
Yes, Dr. Hello. Can you hear me, Dr. Neena?
So can I be seen and heard clearly?
Yes, Dr.
Okay, thank you. So I think we will start now and we will talk about the pre-test, post-test a bit later again. So I would like to welcome everybody to this CME session that has been organized by UEMS and the Health Plus Network of Specialty Centers, along with Moorfields Eye Hospital, Abu Dhabi. This is a very good opportunity and it has come at a very opportune time because we have just celebrated the International Women's Day. And today we are here to talk about a very, very important topic for women. I'm Dr. Neha. I'm a specialist obstetrics and gynecology at Health Plus, and my clinic is at Health Plus branch Al Bandar. So I've been in OB/GYN for almost 18 years, and this topic has really become very close to my heart. I have done my basic training, my MBBS from India, and then followed by my MRCOG UK in 2015, and currently practicing here. So I welcome you all to this session, and I hope that it will be an engaging session where all of us will learn from each other. And without much ado, let's start. So I would request everybody to please stay on mute. Thank you very much. So we're going to talk about the symptoms of menopause and how to diagnose when a person who comes to you is menopausal. What are the symptoms and how to differentiate normal from abnormal? What is the role of HRT? Does this particular patient need HRT? And then how to discuss that with the patient, how to counsel the patient, the pros, cons, risks, etc. Menopause is basically a very natural event that's going to happen in almost every woman's life. It is the final menstrual period. It's confirmed after she's not had a period for 1 year, and it's mainly because the ovaries cease to function. The average age is about 51, but the range is varied. And it can be induced prematurely from medical interventions, like if somebody's had a removal of their surgeries, any chemo, radio for any other cancer, or earlier for any reason if the ovaries cease to function normally. The classical symptoms that a patient will present is a change in menstrual cycle pattern. I'm sorry, but can Dawn try not to put marks on the screen, please? Thank you. I will just clear. Okay, we'll continue. So the classical symptoms are basically a change in menstrual cycle pattern, which could be that the person starts having more frequent periods or periods get further and further apart. There might be vasomotor symptoms, classically described as the hot flushes, which include night sweats as well, and vulvovaginal symptoms, dryness, itchiness, difficulty in intercourse. And other symptoms that might be associated are sleep disturbances. They may only present to you with memory loss, brain fog, or even depression and anxiety-like symptoms. So all of these are important to look out for in women in that age group. So perimenopause is the time around menopause. So it may start even before all the symptoms set in, and there might be just some of the symptoms in the beginning. And it is the most symptomatic phase for this transition and can last up to 10 years around the menopause. So what are the changes in the menstrual cycle pattern? We find that there could be lighter bleeding. They may say that the bleeding has suddenly become heavier, the bleeding has increased in duration, or the cycle has changed. It's not coming regularly, or it's coming later and later, or they may even skip their periods. So any of these symptoms should alert you in a woman around between 40 to 60 years of age that it could be something to do with the menopause. Anything abnormal. So if there's heavy bleeding, she's saying I'm suddenly starting to pass clots, the bleeding is lasting more than 7 days, or it's more than 2 days, what it used to be. The gap between first day to first day of the next period is less than 21 days, or any or spotting or bleeding, whether it's related to postcoital bleeding or otherwise in between periods. Sorry, I think I was mute. I will repeat that. So any abnormal bleeding, heavy bleeding lasting more than 7 days, or the gap being less than 21 days, or any spotting or bleeding between the periods, especially after intercourse, is not to be ignored and should be investigated. So vasomotor symptoms, like we talked about, is that hot flush, that sudden feeling of being hot, especially in the upper part of the body and face. And they say they might feel red, they might start sweating profusely, and more than 3 out of 4 women in perimenopause or menopause will have this history. It is triggered by small sudden increases in temperature, and the treatment would basically depend on what is the severity, what is the risk, any other risks that allow us to give certain medications to the woman, and also her own attitudes and keenness to go on medication. So what happens is that there's a sudden increase in the core body temperature. The heart rate increases. There's an intense feeling of heat in the upper part of the body. The heart rate peaks, the skin blood flow peaks at this point, sweating starts, and then that brings down the temperature, and there is followed by sometimes chills and shivering as well. So this is the physiology. The vaginal symptoms are basically 10 to 40% of women who are in the peri or the post-menopause would complain of vaginal dryness, vaginal irritation, even difficulty or pain during intercourse. And this statistics can be as high as 80-84% in some studies. So it is a very common problem, and it does bother women a lot, and it is progressive. So it tends to worsen as the woman is going through this transition. The management would basically be to encourage her to have regular sexual activity using lubrication, so as to maintain the function of the vagina. And also we can add local vaginal estrogen, and we'll talk about the treatments again together later. And this then affects the sexual health. So there are two components to it. One is because of the decrease in estrogen, there is a decline in the vaginal lubrication, elasticity, making coitus painful, uncomfortable, and not, women are then not so interested. And the other reason is the declining testosterone. So that causes a decline in libido, sexual desire, and that again impacts their sexual health. Encouraging them to continue to have an active sexual life using lubricants, and again, like local vaginal estrogen can help. And then there is systemic therapy as well that can sometimes help with this. So sleep disturbances, not just because of hot flushes, but because of other reasons, have also been seen in these women. And that generally, that is why they would present to maybe their GP or to their gynecologist, because they're just not being able to function. It could be either because of, they have to get up at night to pass urine, or they are having difficulty in breathing at the time when they're sleeping, or due to anxiety and depression issues, negative mood, and then of course because of the hormonal changes. So the hot flushes can trigger awakenings. They're usually in the first half of the night. In the second half of the night, there is REM, and that suppresses thermoregulation, so that also reduces the hot flushes. And again, the decision to treat will depend on the severity, how much it's affecting her daytime life, how much it's affecting her quality of life, and the context. So what is the reason behind it? Is there any other reason that we are missing? So all of that needs to be evaluated. Cognitive changes, research has shown that it's not really linked to the estrogen changes or the hormonal changes, but it might be just a normal aging process. But we do know that many women come to us around this time saying that they're not able to remember things, they have brain fog, and they can forget things even while they're doing it. So this is something that we should support women in and not ignore it. And HRT, although not primarily aimed at this, but can help women feel better. If they sleep better, if they feel better, usually, this either gets better or bothers them less. Mood disorders. This is again a very common problem, and it does bother women at this stage a lot. And those women who've had history of premenstrual tension syndrome or significant stress in their life, they're going through a significant stress. In this last 1 year, we've seen much more of that. Women who are having sexual dysfunction, so not able to have a healthy sexual life, physical inactivity, and those who are bothered by frequent hot flushes, they tend to be more vulnerable. They feel low, they feel depressed. They even say that, I've lost the person I was. They don't recognize the person they've become. And they're guilty, they're feeling guilty about their family, how their husbands perceive them. So there's so many issues that are going on. And of course, the hormonal changes are not helping. So this is again something that happens around this time, and relaxation and stress reduction techniques, yoga, meditation, all of that helps. But then yes, we will talk about definitive treatment as well. Now, urinary symptoms may be linked to the vulvovaginal dryness and lack of estrogen in the vagina, but there is also an increase in the symptoms of stress or overactive bladder or urge incontinence. And this tends to decline once menopause has settled in. But what can help at this stage is advising women to focus on weight loss. Kegels exercises, even at this stage, can help reduce 50% of cases. And then, of course, medications for overactive bladder if needed. Vaginal estrogen may help a little bit in this in urinary symptoms, and especially in recurrent urinary tract infections at this age. So it's worth a try if there is no reason or no contraindication to using vaginal estrogen in these women. Now, osteoporosis is defined as a compromise in the bone strength, and a large number of women, now that women are having a longer post-menopausal lifespan, they're suffering from osteoporosis. And the biggest risk is the fractures, the pathological fractures that may come with it. Now, the lowering of estrogen at this time causes almost 2/3 of the bone loss around this 5 to 7 year period. So it's a huge chunk of bone loss that we see around this time. And supporting women medically and with lifestyle can help reduce this, and therefore reduce the impact of fractures in older women. Now, definitions based on the bone mineral density test that you will order is if the T-score, it will come back as a T-score. So if the T-score is greater than or equal to -1, so from -1 to 0 or +1, that is normal. If it is between -1 and -2.5, that is mild loss, so osteopenia. And if it is less than -2.5, then it is certainly osteoporosis. So this is one way, this is one test that you can offer to women. And if they have, especially if they have family history of osteoporosis, if they have been smoking or if they are obese, and then if they've had any history of bone disorders in the past, then you must offer them this test at time of menopause. So you recommend them for a bone mineral density test, and then you offer them lifestyle changes. So exercising, weight therapy, weight exercises, and drug therapy is an option. And the drug therapy is more important for women who had a history of vertebral or hip fracture, or they have osteoporosis. So the score in the BMD is less than -2.5. Or if the score is between -1 to -2.5, which means they're in osteopenia, but their FRAX score, which is the risk of major osteoporotic fracture in the next 10 years, is at least 3% or more. So this FRAX score can be calculated. The tool is available online. If you just Google for FRAX score calculation, You will get that online. You can put the patient's age, weight, history that they will ask you. You will put in the BMD score, and the FRAX tool will just tell you what is the risk of fracture in this woman in the next 10 years. If that risk is more than 3%, then you should talk to the woman about therapy, because that will significantly reduce her risk of a pathological fracture in the future, which can be debilitating for women, especially working women, even homemakers, because the woman is the backbone. So if we can prevent those kind of fractures, then we can really improve their quality of life. The medical options with normal BMD or even mild osteopenia can be just calcium and vitamin D replacement, along with regular exercise, and these should be weight-bearing exercises. But we may sometimes need to add bisphosphonates if we are finding osteopenia or their FRAX score is high. Alendronate, etc. are some of them. Then there are newer drugs like denosumab and romosozumab. These are given injectable, and these have the advantage because bisphosphonates only inhibit osteoclastic activity. So they inhibit further resorption of the bone. But these other newer drugs that are now being given, they not just inhibit osteoclastic activity, but they promote bone formation. So women who've already had, osteoporosis on BMD testing, for them, these are even better. So, you should consider offering her those medicines. And then, of course, HRT. So if she has other symptoms as well, and you are thinking of HRT, you are wanting to discuss that with her, this is an additional benefit that you can offer to her. Cancer is something that is not really linked to menopause or caused by menopause, but it is in that age group where we see more incidence of certain cancers. So breast cancer incidence does increase in this age group. So the US guidelines recommend that between 50 and 74, we offer a mammogram every 2 years, but in Abu Dhabi, the Department of Health advises starting it at 40 itself. Then screening for colorectal cancer. Endometrial cancer screening is not really a screening, but if a woman presents with any abnormal bleeding, you must have a scan to look at her endometrial lining and make sure that it's normal. If need be, please go ahead, do a hysteroscopy, endometrial biopsy, rule out malignancy, especially if you're considering giving her any sort of hormones. Ovarian cancer, again, is seen more often in this age group, but unfortunately, we don't have a very good screening test for that. But if a woman presents with symptoms like bloating, feeling of heaviness, any pain in the pelvis, just get a scan done, at least a transvaginal scan, and make sure that there is no abnormality in the ovaries, no free fluid, etc. Cervical cancer, thankfully, the incidence starts going down in this age group if they've been regularly screened. So if they have gone through screenings, you can reduce to every 5 years after 45 or even 50. And then after 65, if their previous pap smears have been normal, you don't have to offer pap smear to the women. It's actually very difficult technically to get some cells in a menopausal lady who's 65 or more. And also it's very uncomfortable for the woman. And we found that mostly they will come as inadequate or not showing anything. So if they've had all previous normal smears, you can safely reassure them and you need not offer them a pap smear. Now we come to how to manage these women. So now we've got the symptoms. We decided that there are a lot of issues that the patient has. And now we will talk to them about hormone replacement therapy, which is the pillar of therapy here. Of course, we will talk about other alternatives as well, but we'll start with HRT. Now, I haven't talked about investigations for menopause because really menopause is a clinical diagnosis. Perimenopause is a clinical diagnosis. You don't need to do blood tests or any tests to diagnose menopause. As long as the woman is in that age group, she's having the symptoms, it's pretty obvious that it is related to menopause. However, in certain group of women, for example, who come to you at less than 40 years of age with some of these symptoms starting, there you would want to know by doing some blood tests like FSH and estrogen levels to see whether it is perimenopause starting or some other hormonal issue going on. Again, in women between 40 to 45 years of age, and we get a lot of that nowadays, who are still wanting to be fertile, who still want to know how long they can try for a pregnancy, or even concerned about early onset of symptoms. For them, yes, you could offer blood tests on the second or third day of the period, get a LH, FSH, estradiol, testosterone done, see if there's any other reason to explain their symptoms or whether the menopause is setting in. So a rise in FSH is the first thing that you would notice, and if it is above 25 or 30, it's more or less sure that it is menopause. But in younger women, please repeat it after 4 to 6 weeks so that you are sure that you're not dealing with something erratic, and you are confirming the diagnosis for them, because it's actually quite a setback for younger women to come to know that they're already reached menopause, which they usually assume will come much later. So yeah, it's a slightly more sensitive approach we need to have for younger women with these symptoms. And then we'll talk about now HRT. So HRT is the only therapy, drug therapy, that has been approved by the FDA and also internationally across the world. And you could have two kinds, basic groups of HRT, either estrogen alone or estrogen and progestogen alone. So estrogen alone can be systemic, could be in the form of pills, patches, vaginal rings, or it could be just local, like a cream, which is put for the vagina. Now, estrogen, this is basically aimed for women who don't have an intact uterus, who had a hysterectomy for some reason. And then in them, we don't need to give progestogen, because progestogen's main role is to prevent unopposed estrogen on the action on the endometrium, which may then lead to risk of endometrial cancer. So to protect the endometrium, we need to add progestogen for about half the cycle. And that is where the role of estrogen progestogen therapy comes in. Nowadays, we also have bioidentical hormonal therapy, which consists of hormones which are very similar to those made in the body, but this is not yet approved all over the world. So FDA has some approved options. The RCOG and the British Menopause Society do not support or approve them yet, because there's not real research about their use and side effects. And also there is no standardization of preparation. So they might be from compounding pharmacies, and you don't know how much dose the patient is actually getting. So the benefits, you will obviously, tell the woman that this will certainly reduce your vasomotor symptoms. Some women have instant benefits, but some need weeks. And there is going to be improved sleep, better quality of life, less effect on mood, and of course, vaginal dryness and sexual difficulties will improve. And an additional benefit would be that the bone mineral density, especially if it is low, will improve. If it is normal, it will be maintained. So those are the benefits that the woman can get if she decides to go for HRT. So how do you give it? What is the route of administration? How to start, when to stop? All of this has to be individualized. Till recently, the dictum used to be that the smallest dose for the smallest duration of time, because we know there are some risks, and we will talk about those risks. However, now the norm has become that we try to give the lowest dose, but we individualize it to the woman. So there is no definitive statement that only 3 years should be given or only 5 years should be given. But yes, we try to give it between 50 to 59 years of age, which is the golden period, and try and avoid starting it very late or more than 10 years after menopause, because the risk is greater in that group of women. And if you've been using it for more than 3 to 5 years, then yes, there is a slight increased risk of breast cancer. And this was mainly seen in the WHI and Million Women study in the group that was given estrogen and progestogen. So that was the surprising finding. And if estrogen therapy alone is being given, then there's not much increased risk of breast cancer. So consider each woman's priorities, risk factors, and then initiate the therapy. So there are 3 main ways that you can give HRT. If the woman is perimenopausal or less than 1 year since her last period, which means till recently she was getting some sort of a bleeding, you could either go for, so you have to go for some sort of a cyclical HRT for at least 1 year. Now this could either be cyclical, sequential, or combined. So it has estrogen and progestogen both, or it could be simple cyclical, and I will tell you the difference between these two. So cyclical, sequential, combined, like we have Femistin, Conti, or Let's Do It, they have for the first 14 days only estrogen, estradiol valerate, or some preparation of estrogen. And then in the second half, the next 14 days, it is estradiol plus a progestogen. And the progestogen could be dydrogesterone, dynogest, it could be even norgestrol, but basically, the first 14 days is only estrogen. The next 14 days is estrogen and progestogen. And this is cyclical, but it is taken continuously by the woman. So it's a 28 pill packet, The lady will start it, and then when the 28 days finish, she will start the new packet. When she finishes one packet, she may get a little bit of a bleed, but that is normal. And as long as she's on this therapy, you don't need to really investigate that cyclical bleed that she may get. The other form of cyclical HRT is what we get actually in the UAE, which is Progyoton. Progyoton has a 21 pill packet. So there's a slight difference here. In that packet, in the first 10 days, you have estradiol. And in the first 11 days is estradiol. And the next 10 days is estradiol plus progestogen. So it's a 21-day packet. And once that finishes, the lady will be asked to take a 7-day break. And in that break, she will get a period. And then she will restart the next packet. So the difference here is that there is a 7-day window where the woman is not on medication. And some women have come back and said that they don't feel so good on that 7-day window. Unfortunately, we don't have the options of. We just wait for the, yes, I thought that was a Ferrari in our midst. So basically, yeah, we can use cyclical HRT, which is available here, which is Progyoton. The combined sequential is, we don't have much options here. Now, the continuous combined HRT, which is taken continuously by the woman, and it has estrogen and progestogen in every pill. So it is not based on the time of the cycle. Every pill has estrogen and progestogen. And this is taken again continuously by the woman. And there might be some spotting in the first 3 to 6 months, but usually after that, they should not have any bleeding. So once a woman it's been 1 year since her last period, or it's been 1 year since she's been on the cyclical therapy, you could shift her to the combined therapy as well. Now, before you start, you will talk to the patient, of course. You will explain what your diagnosis is, how you think this will help her. Then you will take a detailed history and examination to rule out any contraindications. So if she's had any unexplained bleeding which has not been investigated, you should not start straight away HRT. Investigate that, rule out any endometrial disease, and then start. Any active liver disease, history of endometrial or breast cancer, heart disease, stroke, dementia. Thromboembolic disease is very important because HRT increases the risk of DVT and stroke. So that should be ruled out. If need be, if there's any doubt, tests can be done to see if there's any hypercoagulable state, then hypertriglyceridemia and porphyria history. Irregular bleeding, like I said, can be there in the beginning, but it should stop by 6 months. If not, you need to investigate and not ignore that symptom. And also remind the women that this is not contraceptive. So especially if you're starting in a younger woman, they should not think that it's contraceptive because pregnancies have been known to happen at this age even. So if they're less than 50 years of age, they should use contraception for at least 2 more years. And if they've had menopause at more than 50 years of age, at least 1 more year after their last period. There is no evidence to show that HRT causes weight gain, so you can reassure your patients. History of endometriosis, if it's there, it may get worsened, so you need to keep a close eye and really discuss the pros and cons with the patient. A migraine may worsen and even fibroids can grow. So again, you have to keep an eye and explain to the woman and involve her in an informed decision. Most women will come and say that we don't want HRT because I will get breast cancer. This is what is, out there. But you need to tell them that there's a very slight increased risk over 5 to 7 years of use, or for maybe 2 to 6 extra cases per 1,000 women, or even of stroke or clot formation is probably just 2 extra cases over 1,000 women over 5 years. So, you have to encourage them and reassure them that the risk is really not that significant and they should be aware of it, but they don't have to not take HRT because of these apprehensions. Now, once you've started HRT, if the woman comes back to you with certain side effects, this is what you can do. So the estrogenic side effects may be breast tenderness, enlargement, leg cramps, bloating, nausea. Try in those cases to reduce the dose of estrogen if you have an option, or change the route. Transdermal routes are always better because they give less side effects and less first pass metabolism. Or if they have a nausea, try and tell them to take it after food, maybe not in the morning, before sleeping, and try to change the route. Before I go ahead, can I please ask the audience not to not to put marks on the screen? Thank you. So If there are progestogenic side effects, you again, breast tenderness, abdominal pain, mood, skin changes, then you can either change to an alternative progestogen if you have that option with you. Again, in UAE, we don't have many options, but you could combine it from a different prescription and or change the route, or even think of going to alternatives like Tibolone. So once you've started HRT, you ask her to come back in 3 months. By then, the effect of the HRT should have come, and you can review and decide how long you want to continue, mutually agree on that. And then you have an annual review for effectiveness, any side effects, any changes in her health, like in blood pressure, her cholesterol, any new illnesses developed, any surgeries done, and then follow up on her osteoporosis as needed. Usually we would do a BMD, and if it is showing abnormality, maybe repeat in 2 to 3 years, depending on the therapy. And there is no limit that when you have to stop the HRT, you can go on. But usually we would, at least by 60, we would like to sort of talk to the woman about going off it. Now, although we recommend that HRT should be withdrawn slowly, internationally, there's no clear guideline on that. The difference is that if you stop the HRT slowly, there is a less chance of short-term recurrence, but there's no impact on the long-term recurrence of symptoms. But if you stop it suddenly, even the short term, she may have some recurrence, but in the long term, it will all settle down. So if a woman is not the right candidate for estrogen and progestogen therapy, or she doesn't want to take HRT, but she's happy to consider a non-hormonal preparation, then you could look at Tibolone, which is a non-hormonal SERM. And luckily for us, it is Lidial, which is available here. So that's a very good option for women in the UAE who want to be on some sort of therapy for their menopause. It has combined estrogen and progestogen and also some androgenic activities. So it improves not just hot flushes, but also sexual function. There is a small increased risk of stroke and breast cancer also with Tibolone. So this must be explained to the women, and they don't need a progestogen with it. So that's the advantage also, that even with intact uterus, they don't need a progestogen to be added on, and they can take this continuously. Now, if they are not candidates for either, or they don't want to take any sort of medication, then a non-hormonal, completely non-hormonal option could be something like antidepressants. Now, paroxetine is one of the only drugs by the FDA for the use for menopausal symptoms and hot flushes, and it has been shown to show improvement in maybe 60 to 80% of the symptoms. So it's pretty good for women who don't want to be, or who cannot be on HRT for their medical conditions. Things like hypnotics, anticonvulsants like gabapentin, clonidine, these are all medications that have been used and have been quite effective. Maybe not as effective as actual HRT, but still quite effective in helping women with their symptoms. There are other alternatives out there in the market. Internationally, you get a lot of these like black cohosh, cranberry, St. John's wort. We have preparations of black cohosh in the UAE. Remifemin is a preparation of black cohosh. Again, it's not really approved by FDA or the British Menopause Society or the NICE, but it is available out there, and women prefer sometimes to use herbal preparations, and it is their choice, but you need to tell them that it is not approved. And secondly, it does not necessarily give them a constant level of hormone, because we don't know what is the preparation contain, and also we don't have any much of estrogen it converts into the body. And then there can be estrogenic side effects if it's taken unsupervised. So I find it best to talk to them about it. If they are interested, or if they're already on it, I discuss it with them so that if they have side effects, at least they feel free to come back to me. If we just brush it under the carpet, sometimes women don't even come back and tell you that they're having side effects. So I like to encourage, I tell them the facts, but if they still decide, then I tell them to come back to me if they have any red flag symptoms. These days, we even have something called Menopearl, which is a combination of red clover and hyaluronic acid. Again, something that is being marketed for menopausal symptoms. And again, something that is not entirely approved by international bodies. And then there is some other over-the-counter medicines which we don't really have in the UAE. Along with this, there are relaxation techniques that you could advise her, a healthy diet, regular exercise. These are not replacements for HRT, but while women still have some mild symptoms, they may try these things to reduce the severity of their symptoms. So like, for example, avoiding caffeine and alcohol also reduces the incidence of hot flushes, making them easier to manage. Dressing in layers, when they're sleeping, not having the air conditioning too cold or too hot, so ambient temperature to be maintained, and also use lubricants, moisturizers, etc. for sexual health, which also makes them feel better overall. So that is what I had to say about the topic, and now the floor is open for any questions. I think Dr. Tahira is here with us, and I will just ask her if there are any questions on the chat box.
Thank you very much, Dr. Neha. That was fascinating, a nice overview on the subject. We've got few questions that I've noted from the audience. Can you remind the audience or the ladies in the audience about the regulations and guidelines of pap smear frequency, please?
Okay. So normally, so there are different guidelines based on American or British guidelines. The Americans start pap smear screening at 21 years of age, whereas the British guidelines start at about 25. Then on, women are generally offered a pap smear every 3 years. And here in UAE, we would start at about 25 if a woman is married and sexually active. Then we would start at 25, again offering the lady every 3 years a pap smear. In certain countries, and hopefully in the UAE soon, we may have a combined test with pap smear and HPV, which can then be done every 5 years. But at the moment, we are offering a pap smear every 3 years. Once they reach 50 years of age and their previous pap smears have been normal, you could start offering the pap smear every 5 years because the incidence of new abnormalities is quite low in this age group. And then once they reach 65 years of age and their previous 3 smears have been normal, there is no complaint of postcoital bleeding, there's no suspicion, the cervix looks healthy, in that case, you need not offer them pap smears after the women have turned 65. So that is the guideline. The exception to that is if they've ever had any pre-invasive cells on their pap smear or biopsy, then they would probably be advised an annual smear till 20 years from that incident have passed. But if everything has been normal, every 3 years till 50, every 5 years till 65, and then stop.
Perfect. Another question regarding the cyclical bleeding. Would you recommend the continuous use or the cyclical shedding of the endometrium?
So very good question. This would depend on how long it has been since her last menstrual period, what is her age, and what are the other medical conditions. So if a woman comes to you at 48, 49, or 50, 51, still had a period till 6 months back and starting to have menopausal symptoms, you would start her on cyclical sequential, in which she will continue to have some sort of a bleed every month. If that bleeding is regular, coming every month at the same time, then you don't need to investigate or worry about it. However, if she is having, despite being on hormonal therapy, she's having erratic, irregular bleeding, and then you should investigate that and rule out any other cause. After 1 year of being on this therapy, or after 1 year of not having had a period naturally, you could then think of continuous hormonal therapy. Once the patient is on continuous hormonal therapy, she should stop having these regular bleeds also. But in the first 3 months, there might be some irregular spotting, which is a natural response to the hormonal medication. So you can reassure her. However, if it continues more than 6 months since you started therapy, she's compliant with the medication, you know you're on the right medication, and she's still having the symptoms of bleeding, then that needs to be investigated, rule out endometrial disease, rule out whether it's atrophic vagina that's bleeding or any other cause, and accordingly manage the patient.
Just again, the use of HRT in premature ovarian failure, for example, a woman between the age of 30 to 40. What's your take?
So it's a very crucial thing, and I couldn't cover it in detail here. So premature ovarian failure is a condition that really affects women, especially because they are younger and they need to have their periods not just for their own health, but also for this, not just for their psychological health, but also for their bone health and cardiac health. So we must counsel them that replacement of hormone is better for them. The pros are much more than the possible cons. The research has shown that the risk of breast cancer or thromboembolic disease with such young women on HRT is very negligible. and the benefits are much, much more. So you can have two approaches to that. If she's really young, between 30 and 40, you could even offer her simple contraceptive pills. They would give her some form of hormone replacement and give her a cyclical bleed. However, if she's not keen to go on that, or she doesn't fit the criteria, you could give her cyclical HRT, like we talked about, Progyoton, which is more natural and might even support a pregnancy if she wants to plan that in the future. And of course, the combined sequential HRT can also be given. But do encourage them to take it and continue it till the natural age of menopause. So, till late 40s or even 51 years of age, if you continue the HRT, it is really going to be very beneficial for the lady, and the risks are really insignificant at that age group.
Great. Women with migraine headache, would you recommend HRT for them?
So again, migraine headaches have been linked to the hormones, and HRT can aggravate migraines. So this is something that we need to sit down and individualize for the lady. If there is a person who's really not being able to function because of the hot flushes, because of the night sweats, she's not able to sleep, not work properly, and the migraines are really very few, without aura, easily managed with mild medication at that point of time, then you could talk to her about considering HRT, and then reviewing her maybe in 4 to 6 weeks rather than waiting 3 months to see how she's doing. It's really not a perfect solution, but we have to find the best balance for the woman. Sometimes these migraines are triggered by lack of sleep. So if you're able to improve her hot flushes and her sleep, her migraine might actually get better from that. But technically speaking, HRT can aggravate migraine.
There are questions related to the link between breast cancer and cervical cancer. I know this is not the topic, but then if you have a short answer for the attendee.
So there is no scientific basis for a link between breast cancer and cervical cancer. There is a link between breast cancer and ovarian cancer, peritoneal cancer because of the BRCA gene, etc. But there is no link. Breast cancer is caused due to hormonal issues and genetic causes, etiology-wise, and then of course other risk factors like smoking, etc. Cervical cancer is basically a cancer caused by an infective agent called the human papillomavirus. So they are completely different difference in their presentations also, because breast cancer is seen more in women above 40, whereas cervical cancer is more seen in younger sexually active women with multiple partners. So there is no real link, but yes, we do offer screening for both of these, as these are two easily preventable cancers in women.
Wonderful. I've got multiple questions related to management of menopause, management of osteoporosis during the menopause. I just want to highlight that HRT is not meant to treat osteoporosis. It's mainly for the vasomotor symptoms. So if you have patient with starting osteoporosis, you need to do the workup of osteoporosis and consider having the advice of a rheumatologist or endocrinologist for management of osteoporosis, rather than HRT. So HRT is not the drug of choice for osteoporosis. It just helps in women who decides to be on it for vasomotor symptoms. Would you like to add anything regarding that?
I agree with you, Dr. Huda. HRT is not licensed primarily for osteoporosis use. In fact, that is not the main aim of HRT. The main aim is to reduce vasomotor symptoms, and then these are other fringe benefits that we get from it. So when we are counseling women, we tell them that this will be an additional benefit, but we don't start it just for osteoporosis. Yes, we do need to involve this correct specialist and start, but it's good for us to know what options are out there and give the women that information.
All right, I think I have just a few more questions, Doctora. A question related to urinary dribbling and incontinence during the menopausal phase. What's your take?
Yeah, so what happens is that estrogen receptors are known to be present in the lower urinary tract and the vagina. And around menopause, we find that this lack of estrogen or lack of estrogen support to those tissues does cause some urinary symptoms, like women start having urinary irritation, vaginal dryness, which also confuses them. And then, of course, recurrent UTIs are seen more often, and then prolapse. So basically, because estrogen is missing, there's a little bit of a sagging of the pelvic floor as well, sagging of the vaginal tissues, and that has been found to precipitate symptoms in women who did not even have them. So this could be either stress incontinence, or it could be urge incontinence, or it could just be overactive bladder or recurrent UTI. Now, although there is no research to prove that, again, HRT will treat all of this, or that's the main aim of HRT, but it has been found that along with Kegel's exercises, at least local estrogen is given, then that improves the collagen in the vagina and the pelvic floor and does help in improving these symptoms. So along with the main course of therapy, like investigating her for what kind of incontinence, is it mixed, is it stress, is it urge, you can try vaginal estrogen and see if that helps her in her symptoms. Sometimes that little bit support is enough to help them feel better, and then they don't need to go for surgeries or even actual medication for OAB. So that's the role. Again, not the primary role of HRT, but it can be used because this symptom is very common in this age group, not just because of menopause, but because of age-related changes as well.
Perfect. What is the best way to use the estrogen gel?
So we have here in the UAE something called Premarin, which is conjugated equine estrogen. And we normally ask women who have this to take a very small amount. Either it comes with an applicator, or if not, then they can take the tip of the little finger, that much amount every day, and put it inside the vagina and smear it, or put it inside as much of the vagina as possible. They start with using it daily, and then they can reduce it after 2 weeks once they find some improvement in the symptoms to alternate day. And then after 2 weeks of that, maybe reduce it to two times in a week. And then even later, just once a week or once in 2 weeks as a maintenance therapy. So the advantage is that there's very little systemic absorption. So we are not concerned about unopposed estrogen reaching the system, and so we don't need to add progestogen for it, and just using it like this, and then giving them the option of using it sometimes for topical use as needed. That is enough.
Okay, I've got a question related to post-menopausal reduced sexual drive and poor libido. Some people advocate testosterone. Can you elaborate on that?
Yes, so low testosterone around this time is been linked to the low sexual drive and low libido. And again, this is something that can be helped if we have testosterone therapy has been tried. But unfortunately, I am not aware of any testosterone therapy available in the UAE. An alternative that has been used is DHEAS, which is dihydroepiandrosterone sulfate. Those tablets are available, and they have been tried by some people, again, an off-label use, where because of its androgenic properties, it has been shown to improve sexual desire and libido. However, it has some androgenic side effects as well. So things like acne, etc. So some women don't like to be on it for very long for that purpose. There are specific medicines available, like in the US, like ospemifene, which is again not available here. It is a specific non-SERM, again, non-hormonal selective estrogen receptor modulator, which works only on sexual desire and vaginal dryness. But we don't have those options here. So what we normally do offer is, again, just HRT by improving the general hormonal level. There is some improvement in sexual desire and libido as well. Dr. Huda, if you have any idea about testosterone therapy, please do add.
So generally, we do not recommend testosterone use because it most of the time lead to misuse. And then, as you mentioned, that it can cause the hyperandrogenemia, hirsutism and acne, a bit of aggression and so forth. And the preparations that we have in the Emirates are mainly for men, so very concentrated testosterone, and definitely not for women. All right, I've got another question, not related to menopause, but it's related to dysfunctional uterine bleeding. If you can tailor your questions to menopause, that would be better. But then during, while we are waiting for more questions, if you can answer that, please. So in between breakthrough bleeding, what would be the cause?
So if it is a younger woman, less than 40 years of age, who's having intermenstrual bleeding, there can be various reasons like hormonal, structural, and coagulation defects, infections. So that is what you need to focus on. So a detailed clinical examination, look at the cervix, rule out a polyp, rule out infection in the vagina, maybe test for chlamydia, follow it up with a transvaginal scan, look at the uterus, look at if there is any fibroid, adenomyoma, any endometrial polyp, what's the endometrial thickening, is it regular or not, and then look at the ovaries and see if there's a cyst or any reason there. So that's for younger women, a very straightforward approach. And if everything is fine, you don't find a specific structural cause or any abnormality, you can offer them short-term hormonal therapy that should fix it. If there is a cause, of course, you will treat that. In women more than 40 years of age, it becomes slightly tricky because any bleeding more than 7 days or any bleeding in between 2 regular periods should be looked at more seriously. And you again begin by a full detailed clinical examination. You make sure the pap smear is normal and you check on the lining of the uterus. And if that lining appears thick or heterogeneous or shows something like a polyp, then you must offer her a hysteroscopy, which is the gold standard, rule out endometrial disease, remove a polyp, or even offer her Mirena at that point of time. So basically the treatment would be based after ruling out endometrial disease, precancerous cells, atypia, hyperplasia in the endometrium. You can then offer the woman safely hormonal therapy. In older women who are perimenopausal, it becomes all the more significant if they are having irregular bleeding. However, if that bleeding is further apart, like every 2 months, 3 months, scanty bleeding, less bleeding, or it's getting lesser and lesser, then you can safely reassure the woman without any tests. But if it is less than 3 weeks apart, if the bleeding is more than 7 days, if it's heavy bleeding, which wasn't her usual pattern, then again, we have to do the full drill of clinical examination and history taking examination, an ultrasound, pap smear, and find out whether it's a structural cause or not.
Great. I think we're learning a lot from the question and answer session, Doctora. We're getting closer to the end of the session. I've got maybe 1 or 2 questions related to HRT. Would it worsen endometriosis or leiomyoma?
Yes. So that is another issue with HRT. So a woman with a history of endometriosis or who has a leiomyoma fibroid in the uterus, you need to tell her that once we start HRT, there is a possibility that it's not that it will worsen necessarily. It will all depend on how it has been behaving in the recent past. So for example, a woman comes to you who in her 20s had endometriosis, had a good laparoscopic surgery, has been fine since then. For her, it's unlikely that it will cause too much problem. But again, you do review her in 4 to 6 weeks, make sure she's doing fine. If no symptoms, she can continue the HRT. Similarly, for a woman with a leiomyoma, you have to tell her if it's been stable, like small leiomyoma for years, not causing any symptoms, she's been fine for many years, you could offer her HRT, tell her that it may potentially grow, call her back in 3 months, review the size of the leiomyoma. If it's not growing, then you can reassure her and ask her to stay on HRT if it's benefiting her. So yeah, it's not a blanket statement that you cannot use, but you have to use with caution and involving the woman in the decision making.
Fantastic. That's really good. I think if anybody would like to ask any further question, we can either email you, Doctora,
Sure.
or just you have a cancer. All right, I didn't know that you have some.
I know, I just kept it in case we had some time. We have a couple of minutes, so I'll just go over this also. So this is something that somebody asked about premature menopause, is that if there is a lady comes to you, she already has a Mirena coil, so obviously her periods are not very regular, but now she's having some intermenstrual postcoital bleeding, like we discussed, DUB. Again, mood has started changing. But there's no family history of early menopause. So she's asking, am I perimenopausal? Do I need to do any tests? What do I do? So again, like I said, the diagnosis is clinical, especially if she's more than 45. Motor symptoms and irregular periods, then it is perimenopause. If it's no period with all these symptoms, then it's considered menopause. And the role of FSH is only in more than 45-year-old women with atypical symptoms, 40 to 45-year-old with a surgery or change in periods, and of course less than 45 years if you want to rule out premature menopause. On a lady with the Mirena, you can still go ahead and do an FSH, but if it was a lady on oral progestogen or oral therapy, then it wouldn't make much sense to do that test. But if the FSH is consistently above 30, even in this lady with a low serum estrogen, you could tell her that yes, you're probably there in the perimenopause, and talk to her about adding on an estrogen, because she's already on the Mirena. So that's an advantage. She already has endometrial protection, and you could just add on some estrogen. So estrogen in Abu Dhabi is available either as 2 milligram tablets or as 100 microgram patches at the moment, which are given twice a week. Unfortunately, we don't have patches for combined HRT. We don't have a variety of dosages, but we do have some options. So we can help our patients and, start them on something till we can find something better for them. So these are the references, and thank you very much.
Wonderful. I think we approached almost 9 o'clock. Maybe we have 1 or 2 questions there in the chat box. There was one question related: if a woman had an early menarche, would she have an early menopause?
It's possible. Yes, that has been found. But then we also have women who have early menarche and late menopause, which are the women we consider high risk for things like breast cancer. So it's difficult to say. A lot of things determine your last age at last menstrual period. It could be family history. A lot of women follow the pattern their mothers followed, but then it affects how many pregnancies you've had, whether you use hormones. If you've had IVF cycles, some women end up having premature menopause because of that. So there are so many factors that it's difficult to pinpoint one. But things like BMI, exercise level, diet, stress levels. I mean, there's just so much that affects women's health. But yes, this is one of
them. Other questions related to the influence of other hormones on the age of menopause, like hypothyroidism, diabetes. So there are some publications related to diabetes. So a couple of them related to uncontrolled diabetes. So high HbA1c may lead to early menopause. Diabetics in general, type 1 and type 2, are more prone to have early menopause than non-diabetic peers. So again, this is all to do with the insulin resistance that can happen at any time. All right, I think with that, maybe Doctor, if you would close up with the take-home messages.
Yeah, so I would just like to end, and we will send this to you as some take-home slides. Basically, I will put on that it's a clinical diagnosis. Do not wait or depend on investigations to diagnose a lady with perimenopause or menopause. Individualize the treatment, give her the therapy she needs for the minimum duration of time that she needs. 50 to 59 years is the golden period. So be confident, be free to offer them these medications. Women will benefit from this, and we do need to counsel women. There's a lot of information on Google, and not all of it is correct for their own health. So we do need to counsel them, spend time with them. And once you start HRT, be aware of the side effects, be aware of how to separate the normal from the abnormal symptoms, and you will be absolutely fine in managing and helping women deal with menopause. So that's the take-home message.
Great. Thank you very much, Dr. Neha. That was fantastic. We had a great interaction from the attendees. Mashallah, you have above 400 attendees for today. Please complete the post-test survey. Very simple questions, and I'm sure all of you will get it all right. I'm afraid we can't provide recordings for lectures at this stage, but you will all get the slides, the key slides needed. We would be working on posting some of the major presentation slides on the website, but we are working on it. Thank you all for your attendance and for your time, and let's go do some work. Thank you.
Thank you very much. Thank you, Dr. Huda.